Two tumors can both be called squamous cell carcinoma and still require very different treatment, because the name is only the beginning of the risk assessment.
Expert host. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Okay, wait, hold on. Before we go any further, why would two identically named tumors be treated differently? I mean, if it's the exact same cancer on the chart, shouldn't it just be the exact same fix?
Section 1. Not all CSCs are equal. And the really short answer to your question is that cutaneous squamous cell carcinoma, or CSCC for short, just isn't a uniform disease. The real danger here is treating its incredibly broad spectrum like it's all exactly the same thing, because it's not. The biological behavior of this cancer varies wildly, which means it demands a highly tailored plan, not just some generic one-size-fits-all approach. Right, so let's look at the contrast here, because it completely dictates the clinical pathway. On one side, picture a really small, sharply defined primary tumor just sitting on the trunk. That's a very forgiving anatomical site, right? The risk of it spreading is exceedingly low. Now, on the absolute opposite end of the spectrum, think about a recurrent, poorly defined, deeply invasive tumor that's literally wrapped itself around a major nerve in a super tissue-sensitive area like the face or the neck. The diagnosis name written on the patient's chart, identical, but the actual probability of hidden microscopic extension, recurrence, nodal spread, and severe functional harm, totally different. Things like location, size, depth, visible borders, and nerve involvement completely rewrite the treatment playbook.
Which brings us right to Section 2, risk versus prognostic stage.
So if just looking at the name on the chart isn't enough, how do doctors actually measure and categorize these dangerous differences, like without just making an educated guess?
Well, they rely on highly specific, evidence-based frameworks. But it is so critical to understand that these frameworks answer fundamentally different clinical questions. For instance, you've got National Comprehensive Cancer Network, or NCCN, treatment risk categories. These are designed to help us choose the intensity and method of treatment today. They look at the highest risk feature present and tell us exactly how aggressively to act right now. On the flip side, you have Brigham and Women's Hospital, or BWH, and the American Joint Committee on Cancer, AJCC-8. These are prognostic systems. They're built to estimate long-term patient outcomes and organize formal staging, with AJCC-8 being specifically limited to tumors of the head and neck. Do they inform one another? Sure, but they are absolutely not interchangeable labels. Put simply, treatment risk creates the action plan, while prognostic stage helps predict the future.
And what's truly revealing here is this sharp outcome gradient. Look at these numbers. In a validated cohort tracking over 10,000 tumors, the adjusted 5-year disease-specific death rate was 0.1% for lower-risk disease. That climbs to 0.5% for high-risk disease, but for very high-risk disease, it jumps all the way to 10.5%. Now, obviously, these numbers represent group averages. They are never meant to be concrete predictions for any one specific individual. But the takeaway is massive. The very high-risk label identifies a subset of tumors whose behavior is far, far worse than what most people picture when they hear the phrase common skin cancer.
Actually, let me stop you right there to reset for a second. Because looking at that massive jump in the numbers, it seems pretty obvious that the most important question is not which procedure is best, but what makes this particular tumor lower, high, or very high risk, and how certain do the margins need to be?
Hit the nail on the head. Section 3, choosing the right margin. Because our ultimate goal is exactly what you just described, we have to match the level of margin certainty to the specific tumor we're actually looking at.
So comparing these surgical approaches builds our strategy from the ground up. Take standard wide excision. It can be an incredibly effective, excellent operation for a carefully selected, well-defined lower-risk tumor. In those cases, just taking a standard 4 to 6 millimeter clinical margin of normal-looking skin around the tumor is totally anatomically acceptable and highly curative. But standard excision relies on statistical assumptions about how far the tumor has spread. Mohs surgery or other complete mapped margin methods is a whole different ballgame. It isn't chosen just to use a smaller scalpel for cosmetic reasons. No, it is absolutely vital when we're dealing with hidden microscopic extension, high recurrence risk, aggressive pathology, or really difficult anatomy. In those high-stakes scenarios, leaving any microscopic residual tumor behind is especially costly. Mohs provides a mapped feedback loop between surgical removal and immediate microscopy. It examines 100% of the surgical margin to ensure the cancer is entirely, completely gone.
Okay, but what about the simpler stuff? Can't we just, scrape it off in the office, or maybe just use a topical cream instead of putting someone through actual surgery? Yeah, We have to be very precise when talking about those options. Electrodesiccation and curettage, which is scraping and burning, or topical treatments, are strictly reserved for carefully selected lower-risk or in situ disease. In situ basically means the cancer is confined completely to the topmost superficial layer of the skin and hasn't invaded any deeper. Those simpler methods should never ever be used as general substitutes for margin-assessed surgery in invasive, higher-risk squamous cell carcinoma, period. The risk of leaving deep invasive tumor behind is just way too great.
And this leads us perfectly into Section 4, beyond the primary tumor. Because for those very high-risk tumors we've been talking about, achieving local clearance of the skin is absolutely necessary, sure, but it might not be the end of the entire treatment plan. We frequently have to look beyond just the skin itself.
This often means introducing targeted imaging and nodal staging into the protocol. But let's be clear, a scan isn't just some automatic badge of thoroughness applied to everyone. It is risk-triggered and highly question-specific. For example, a contrast-enhanced CT scan is typically used for nodal staging in the neck or other regional basins. An MRI? That's heavily preferred if we suspect perineural spread, which is when the tumor is actively moving along nerves, potentially toward the base of the skull. Ultrasound, meanwhile, helps evaluate superficial lymph node basins. Basically, nerves, nodes, and imaging enter the treatment plan selectively based on very specific clinical questions, rather than just automatically for every single patient who walks through the door. Then, in the most advanced cases, systemic therapies enter the picture. The data from the CPOST trial really illustrates the power of this approach. Selected patients with advanced disease who were treated with surgery and postoperative radiation had a 24-month disease-free survival of 87.1% when they were given adjuvant semiplimabad, which is a PD-1 immunotherapy. Now compare that to just 64.1% with a placebo. It demonstrates so clearly how systemic treatment helps in advanced cases by recruiting the patient's own immune system to fight the cancer. Though it is important to note clinically that while this mature result firmly establishes a significant disease-free survival benefit, it hasn't established an overall survival benefit just yet.
All right, moving to Section 5, the impact of immunosuppression. So everything we've discussed so far assumes a patient with a typically functioning immune system, right? How does immune suppression, say after a patient has a major solid organ transplant, change this entire framework?
It changes the framework profoundly. Seriously, listen to this. A meta-analysis tracking this specific population estimated a pooled standardized incidence ratio of 45.9 for cutaneous squamous cell carcinoma after a solid organ transplantation. A nearly 46-fold incidence spike. That highlights the profound vulnerability of immunosuppressed patients. The life-saving medication required to prevent their body from rejecting the new organ simultaneously strips away the immune surveillance that would normally detect and destroy these skin cancers.
However, the clinical response to this vulnerability should completely avoid fatalism. Yes, immune suppression absolutely lowers our threshold for careful, deliberate risk assessment, complete pathology review, and highly coordinated multidisciplinary care between dermatologists, oncologists, and transplant teams. We're on high alert for sure, but it is crucial to remember this does not mean every single tumor will automatically spread, nor does it mean every single tumor automatically requires the exact same intense, massive operation. We still let the specific tumor's individual features dictate the treatment intensity. The ultimate treatment plan just has a much narrower tightrope to walk, you know? It has to protect the patient from the skin cancer while simultaneously protecting the transplanted organ that made their long-term survival possible in the first place.
Finally, we arrive at Section 6, surveillance and next steps.
Okay, so after the whole assessment is complete and the surgery is successfully done, what actually happens next? How do we keep the patient safe moving forward?
Well, follow-up must be directly proportional to the original risk. The vast majority of recurrences happen early on. Because of this, your generic run-of-the-mill annual skin check completely inadequate for dangerous high-risk tumors. For very high-risk disease, we often need proportional surveillance, which means rigorously seeing the patient every 3 to 6 months during those crucial first 2 to 3 years. Conversely, lower-risk disease shouldn't automatically inherit that most intensive, burdensome schedule. We tailor the surveillance frequency entirely to the specific tumor, nodal, and immune risk profile of that exact patient.
So, returning to our opening point, the governing principle across this entire landscape is to match treatment intensity and margin certainty to the actual tumor, not just the generic diagnosis name. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.
For a simpler treatment-by-treatment walkthrough of what we've covered today, your absolute next step is to read the Squamous Cell Carcinoma Treatment Options Guide on Skin Trust. Ultimately, the question isn't just about what kind of cancer you have, but how intimately you understand its unique footprint. Are you simply treating the name on the chart or the actual tumor hiding beneath the surface?